So that's the agenda for today. A quick introduction to the current and also the incoming team members. We're going to go through some member stats, have a quick chat about the pathology webinar, some highlights for the upcoming Toronto meeting, which I think you're all coming to, some planning for this year, including some of the excellent work that's going on behind the scenes with the standards and guidelines documents. And then what I'm anticipating is the best part of the morning, I think, will be, for me, the presentation from Bobby Padera, who's very kindly agreed to give us a presentation on the rise and fall of machines in pathology perspective on technology used in transplantation. So I'm looking forward to that. And we'll have a few questions and answers, or some discussion and questions at the end. Bobby, hope you're okay with that. So this is the current team, and I thought, well, because particularly since I thought there were going to be some new members, it'd be nice just for everybody on the team just to quickly introduce themselves. So I'm Varnathi Sivasubramaniam, as you know. I work at St Vincent's here in Sydney, and I'm the representative for the heart failure IDN, and I'm this year's chair, but I'll be outgoing chair at the meeting. And if I could get the rest of the team in the order of the pictures just to give a little introduction.
Well, hi to everyone. My name is Francesca Lunardi, and I'm a dedicated thoracic pathologist with a primary focus on lung transplantation. I serve as associate professor at the University of Pavia, and currently I am the chair and pathology community representative in the Advanced Lung Failure and Transplantation Steering Committee of the ISHLT. So it is a pleasure to be here with you today, and I hope you will enjoy our town hall.
Perfect.
Katerina?
My name is Katerina Vasiliev. I'm a cardiothoracic pathologist, and I'm currently working at the Bulgarian Academy of Science in Sofia, as well as for the European Commission. I'm the pathology representative at present for the MCS community.
Yeah.
Hi, good evening. My name is Jan van der Tuzen. I'm a thoracic pathologist from Erasmus MC in Rotterdam, and I'm the current rep for the pulmonary vascular diseases group.
Is Federica on the call? Oh no, I've literally just got an email saying she won't be able to attend. So, but Federica is our outgoing Early Career and Trainee Committee member and representative, and she's from the University of Padua. So, and she's been an excellent contribution over the last 3 years. So we'll be sorry to see her leave the committee, but we'll talk about her replacement in the next slide. And is Dylan on the call? Oh, yes, he is. There he is.
How's that for timing? I'm sorry.
Perfect timing.
I heard you asking my name. I didn't hear what you were asking me about. So if
we're just we're just introducing the current professional community representative committee. So
I should introduce myself. Hi, everyone. I'm a pathologist in Salt Lake City, Utah, with the Intermountain Health Group, and I support the heart transplant program here. I have a role, I should mention that too. I have a role in ISHLT, which is, I am part of the Leadership Advisory Forum. I'm one of the at-large representatives for that forum.
So that's the current committee, and all members apart from Federica will continue on to next year at the moment, and hopefully, I'm going backwards. There we go. And this is our incoming early career representative. So Alexander, if you're on the call, can you introduce yourself?
Of course. Hi, I'm Alex. I'm a cardiothoracic pathologist in St. Louis, Missouri at WashU. Currently doing a postdoc in lung transplant, and happy to be part of the leadership.
We're looking forward to your contribution because you already do a lot. And it's just a quick screen, even though we've got the pathology community representative team, we've also got a lot of pathologists in various roles that don't always get noted, but I think for being the 1% of the community, we do actually do a fair bit in terms of contribution. And actually, it's good to have both Elizabeth and Greg on the call, because we might, when we get to the next couple of slides down, talking about the next program for the upcoming Toronto meeting, we might get their input on that. So yes, it's great to have all those representatives in the various committees. Just a couple of stats about look at the membership stats. So as you know, the majority is going to be cardiology and cardiothoracic out of the ISHLT membership, and we make up a lovely, well-rounded 1%, but it's a good 1%. I think it's a very strong 1%, and we're a vital 1%. Without that 1%, it'd be very hard for them to do the transplants, certainly, and monitor. So I think we're an important part of the community.
Vanity,
demographics.
Sorry to interrupt you.
Yes.
How many people are we? How many people are these 1%?
I thought it was the number I saw was 42. Is that correct, Juliet? I looked it up, and
I think that would have increased. We used to be like 30. So
I
it would be
looked
good.
it up and thought it was 42, but I'm not 100% sure,
very
Juliet.
nice.
Maybe I might ask Juliet if she can check that for me, and we can. I think that's correct. When I looked it up on ISHLT Connect. Sorry, Anya, I should have looked that up, but I may be wrong. Don't quote me on it. And the demographics in terms of this year, the membership type, physicians, which we are a part of, although sometimes people forget that. So we make up 61%, and of the regions, as expected, 74% are North America, and we've got 15% in Europe, smaller percentages for the rest of, my Oceania, that's us, 3%. So, we're there. And of the IDNs, as expected, 51% is heart failure and transplantation, so makes up a fair percentage. But, there's a good percentage of lung as well, and then a smaller percentage of the other IDNs. And just to recap, we had an excellent webinar this year, and it was the brainchild of Greg, who came up with the whole concept from a previous symposium. And Maya, who I think is on the call, very ended up doing a solo moderating, but at the last minute, but she did an excellent job. And some excellent presentations from all four presenters. I learnt a lot, and it was, and I think if we have a look at the stats, we had 42 total registrations, 14 live attendance, but interestingly, YouTube views 108. And so that is actually quite promising when you look at the comparison numbers for the larger communities. So given that we're only 1%, hopefully we can do better this year, but I think it's still quite good. Any feedback on that from those who attended? So we'll keep going. So as you know, we're all going to, hopefully we're all coming to Toronto in April for the upcoming ISHLT meeting. Just a quick reminder of the pre-conference workshops that are coming up. If you are able to attend, particularly if you want to encourage the trainee workshop to any of I don't know if you've got any trainees who are coming, particularly from the Northern Hemisphere. Unfortunately, it's a bit far for some of my trainees, but and also I think there's some excellent cardiovascular and thoracic recovery workshops. And I don't know if Greg or Elizabeth, if you wanted to just say a couple of words with regards to the upcoming program.
I mean, I'm very excited about the program. I don't have anything prepared to tell you about it, but I think it's going to be really strong. And yeah, just I don't know, Elizabeth, do you have anything to point out?
No, I agree. I think I'm excited about several of the symposia and some of the mini oral sessions that do have a pathology focus, and nothing other than that, nothing well thought out or prepared to say.
But no, and thank you, because it's always great to have strong voices in the program committee that are pathology focused. So I think it's going to, my quick look at the program looks like it's going to be an excellent, very busy program. In terms of our PC meeting, it is on Friday the 24th from 5:30 to 6:30. I know that not everyone is able to stay for the whole 3 days, so we've, as you know, we've changed the dinner a little bit. And from the IDN point of view, the heart failure is on the 22nd, as well as the PVD is on the 22nd. The lung failure is on the 23rd, and the MCS is on the 24th. Now, Greg, is it true they are doing just the committees this year rather than the big meeting?
Correct. We're just doing the professional communities, and the IDN meetings will be just the steering committee.
And because we've got several of our senior leadership team unavailable to stay for the whole for the PC meeting, we're having the dinner on the Wednesday, so we can hopefully everybody will be there, and it'll be a great chance, particularly for the junior members, to network. So it's Wednesday the 22nd. Slight change in the time. We've made it 7:30. So I think the welcome reception finishes at 7. That allows everybody half an hour. There is the meet the members, meet the mentors at between 7 and 8. So I don't know if any of the early trainee, the early career, want to go to that quickly and then come to the dinner. I will actually be attending for about 15-20 minutes of that. And David Huang has very kindly agreed to organise. He hasn't quite worked out the venue, but if we can RSVP by the 8th, that gives him plenty of time to organise a venue. And I will give a little shout out for Sydney 2027, which I believe I've already been told, and I will have to organise the dinner. So I've got some ideas already floating around. So we might even talk early RSVPs for that. So just plugging, got to keep plugging Sydney for the year ahead. So in terms of planning, we've got a lot planned, and there's a lot of things happening. So as you know, at the moment the Toronto meeting finishes, we're going to be all full steam ahead in terms of 2027 symposium proposals. So there'll be a lot of emails coming out from the professional community and the new chair. And also the various IDNs will be full steam ahead. So that first 3 months, please already now put your thinking caps on, have a look at the program, see what we didn't cover this year, and think about what we can add for next year. So we're all ready to go. As soon as the meeting finishes, you've got some ideas. There's a lot going on in standards and guidelines documents, and I have asked the leads from each of the projects if they can discuss where we are with each of them. So we'll go on the order that's up there. So for the explanted native allograft hearts, Annalisa, would you be able to give us an update on where we're?
Yeah, I think we are closer to a final draft that I will post on Google Drive, because we have been reviewing extensively the first submission. The 7 reviewers made very extensive comments and asked for reshaping all the documents. So I have to cut out all the introductory 30 pages about the introduction of different pathologies, but we try to focus mainly on the methodology and the technical aspect. Then we ran the survey that took quite a lot of time. Now, fortunately, all the 29 members of the task force were able to finish the survey. That was more than 100 questions related to the consensus statement that we want to have as a final summary of the paper. And so the feedback seems to be quite positive, with a percentage of agreement around 80-90% of all the questions that we pose. And so I think by the end of this week, I will be circulating the final, what I consider the final document to be approved by all the members of the task force, and then with the reply to the reviewer point by point. So I hope to have a good feedback from everybody and be able to submit the documents. The standard guidelines ask to speed up a little bit, and so I think I will try to send out all the documents shortly and have a feedback in 10 days, no more, because they wanted to have something near to the final, at least this second draft by the mid March. So the time is quite compressed, and but I thought that it was very important to have everybody on the task force doing the survey, not just to leave somebody apart. And so I am quite confident to be able to reply to the standard guidelines committee in the due time.
Thank you so much for that update. Yes, and thank you for all the effort that you and Jerry have put into putting this together.
Yeah.
We might move on to the next one, which is I was going to ask Anya if she could give us update. And I know you've sent out an email recently, so yes, if you can give us all an update, Anya.
Yes, yesterday. Thanks. So basically, if you recall, there were some hoops to go through before we actually got approved by the Standards and Guideline Committee, but we finally got approved, and I think it was in May, and we had a call at the time, and we came up with who is going to do what. And then we first sent out a survey, which was sent out to the ISHLT pathology community as well as PPS. So thanks everyone for filling it in. We had 43 responses. Some were from the same institution. So if the question was about the protocol of the institution, there were very similar answers. So, but I've summarized it all and sent it around to the writing committee yesterday. Like Annalisa said, we get a little pressure from the standard and guideline committee. So I set a deadline of the next 2 weeks for everyone to submit their paragraphs. I mean, these paragraphs are only like 500 words, so it's not like we have to write each a huge manuscript. And yeah, then we go from there.
Thank you. So next I'm going to call on Fiorella to talk about the statement on pulmonary AMR and proposed graft antibody pathology. And I've got some slides that she wanted me to share.
Yes, I prepare a few slides just to keep track of the key dates and tasks for these two statements. So Langemar has had a long and challenging journey, but it seems now to be close to its goal. This is a powerful example of resilience, and I would like to thank everyone has contributed, and in particular the co-leaders, Deborah Levin and Ramsey Hashem, for their collaboration and titanic perseverance. So we started in 2021 to update the statement. The previous statement was published in 2016, and we approached the Delphi method. And this started in 2021 after the working group was established by the IDN, Advanced Lung Failure Transplantation, and SNG. And the first draft was submitted in 2022. 2023, following new guidelines released by the SNG committee, the work was not accepted in its format, and we were asked to revise it, mainly focusing on the definition, on the EMA definition. The new EMA definition is now named with the acronym GAP, graft allograft pathology, and we have now completed 2 rounds of revisions with more than 20 pages of concerns, and the latest feedback is only a minor concern. So we are hopeful this will soon lead to a positive outcome, allowing us to release an update EMA statement 10 years after the previous one. Next, please. In parallel, we are working on another important statement. In other words, we are updating the working formulation on rejection published in 2006, and we are hoping for a smoother process. Before showing you briefly the structure of the new statement and where we are now, I want to thank all specialists who contributed to this survey that was published on the International Journal of Lung Transplantation Open. It has provided valuable insight that will be included in the statement. Next, please. I am excited to be coordinating this statement with David Young and 2 skilled pulmonologists, Deborah Levine and Glenn Philip Westel. And the working group includes 28 participants, and more than half are pathologists. The statement includes 7 sections. 3 focus on acute chronic rejection and ancillary techniques, and are being developed through a systematic review with the specific grades and recommendations. And the remaining section follow a narrative approach, and this section 1 and 4 and partially section 7 are completed. Surely this will be then revised when the other 3 sections will be completed. Abstract and the text double screening has been completed for all systematic sections using Covidence, and as expected, we screened a huge number of articles, 13,000 articles. Thanks everybody for this great and important work. And despite some delays due to a large number of articles and change in the information specialist supporting us with bibliographic analysis, we are now back on track. In other words, we are writing the grade recommendation for section 5, and we hope to be ready to vote by the end of March. And we aim to release the first draft before summer. And we hope that this statement will be ready by 2026, 20 years after the previous one.
Thank you so much, Francesca. There's so much, Fiorella, there's so much work that you're doing. It's just amazing. I don't know how you have time to actually get through your day because there's so much research going on. The next couple of updates are, I think, new ones. But would be excellent to have both Katharina and Greg give us an update, which are newly accepted proposals, which I think are in the early stages. So Katharina, if you could give us an update on the first one, the cardiac allograft vasculopathy?
No, well, we were about to meet today half an hour earlier. Unfortunately, due to a schedule clash, we were unable to meet. So we are going to reschedule till Friday. We have received several applications for the writing committee, which include also pediatric specialties, which is great for this topic. So we were really happy to have received so many applications, and we are looking forward to working with all the different groups. I think this will be a great guideline.
Thank you. And Greg, did you want to give us an update on the revision of
Yeah,
the
so
heart rejection?
so I think this is one that has been flagged as needing updating. So the Standards and Guideline Committee reached out to me and asked me for an application. So I submitted an application and asked Dylan Miller and Marnie Federigo to join me as co-leads. And then they accepted my application and said, "Here's do a follow-up application." So the follow-up application now includes much more details about the method. And timeline, things like that. So I'm working on that. That's going to be due in early March. And they've also submitted, they've given me a list of people who have volunteered to work on it. So we have to put together our team. And so working on that now. But yeah, very, very early. Still need the approval of the follow-up application.
Yep. Excellent work. And in terms of future ideas, I was hoping to call on Dylan just to give a little update about a collaboration with BAMF from a cardiovascular point of view.
Yeah, thanks, Vanity.
Yeah.
I would just like to invite everyone to come to Banff National Park in Alberta, Canada, this October 5th through 10th. There will be a joint ISHLT and Banff sponsored scientific session at the annual Banff conference. It will be on the Wednesday of that week. It's October 7th in the afternoon. And we will be developing a deep phenotyping tool for cardiac transplant biopsies. And when I say that, I mean we'll be defining data fields to capture using kind of a lesion score framework similar to what they've done in kidney transplants. This will be only for a research tool, and it's completely entirely separate from the ISHLT working formulations that are used clinically for cardiac biopsies. But our hope is that with this more sort of granular tool, we'll be able to enable better correlation studies with biopsy data for all kinds of validation studies like new molecular assays, new AI algorithms, and things like that. So we've invited speakers and we have kind of a framework for doing this, but we'd love to have as broad a participation as we can in this. ISHLT, so Mr. Schultz and Dr. Stalick have both sort of endorsed, approved this idea. Normally, the Banff publications are published in the AJT journal, but this report, and it's just a scientific report, it's not evidence-based guideline. It's just going to be a consensus type document. But it will be published in JHLT, and they've defined a pathway for it to go through the approvals for that. They let me know. So that's what's happening this year with the Banff ISHLT collaboration, and would love to see as many as could make it to Banff this fall.
Sounds very exciting, Dylan. Just a quick reminder to everybody for 2026, we have to come up with some pathology webinar ideas and all the ideas for content and speakers and possible potential collaborations. So if everyone sort of puts their thinking caps on, as we used to say when I was a kid, and sort of send in some ideas to the committee, particularly the new once the meeting has come together, that would be great. And then just a quick update from Katerina on a meeting that's happening in May which I think has ISHLT involvement. So she just wanted to give us a quick update and a plug on that as well.
Well, that was an idea to represent something like a training session for Sydney, which unfortunately didn't happen, but we have received endorsement from the ISHLT, for which I'm grateful for, and it became actually quite bigger than that I anticipated. So many former colleagues now participate, from cardiac surgery, from the University of Florida, who has been actually my colleague at the Royal Brompton, or at this part, he was in Harefield. He was the head of the surgery there, of the cardiothoracic one. The lung transplant specialists from Harefield. Many Eastern European colleagues, including those from Russia, and basically also colleagues from the state, including Anya, are going to participate either online or on site, and we are happy to welcome all of them. It will be a hybrid event, and I was able to secure some discounted publication rates for 2 journals. One is in Life, which is something like 3.8, and the other is in, I think, Biomedicines, which is 3.5. For e-posters who wish to submit afterwards. So I'm just entering the program details now. The faculty has already entered to the website. Actually, I'm organizing it, I'm running it, and I'm happy for participation of many of you. And basically, I would like to make it, annual event, for a meeting to come together for those who are unable to attend these meetings in, for instance, in Sydney, because it's, for many European colleagues, it may be quite, let's say, costly, and many institutions do not fund, unfortunately, or do not support participation in congresses which are outside of the continent. So that would be a lovely, meeting to catch up with the newest developments in the field. And I'm very happy, and I'm really grateful for Greg to have supported this format.
Thank you, Katerina. I think we'll so just a quick reminder as well for JHLT special issues. If anyone has some ideas for any of those upcoming issues, that would be, it's always good to have some pathology related articles. And in particular, this is coming up, this will be on the, I think there's an ad on the ISHLT Connect as well. Just to remind, particularly the early career, there's an edition in May. Submit study ideas by Monday, the 16th of March. And it's a great opportunity for early career professionals or any of the trainees that you know. So please encourage your early career professionals or trainees. And all relevant submitted slides that are confirmed to include ISHLT career, early career and training members will be published in the bibliography alongside the final issue. So, there's no downside to actually submitting an idea. So please encourage your early career and trainees to think about submitting. If you've got a great idea, put them on the paper and submit it. So it's good. It'd be great to have some pathology-led articles in that. And just a final slide to remind everybody about the new program which started at the end of last year for the Fellow of the ISHLT program. I believe the submissions have closed for this year's announcements. But I think, personally, I know several members who are already on this meeting. I'm hoping they've submitted, but if not, at least for the following year, who more than qualify in terms of their contributions to ISHLT. And I would highly encourage senior members to nominate, because I think that, the pathology community certainly punches above its weight, and it would be great to have some acknowledgement of some of the senior members who do, quite a bit in terms of, running the standards and guidelines and making a difference in terms of the the direction of ISHLT. So as long as you've been a member for greater than 5 years, I think the minimum number of points, core qualifications, service to ISHLT and commitment to field, which I think a lot of you would certainly qualify for. And they just need to submit 2 letters of recommendation, a CV, resume, and there's a small fee, I think. Greg, I don't know if you wanted to just quickly say a couple of words about this, because I think there's certainly some members on this call and within pathology who would be, I'm hoping, have nominated for this year, but if not, for next year.
Yes, the first class, the nominations are moving through. Actually, is my colleague Nikki on the line?
I am on. I
will hand this over to the person.
Oh, Nikki, sorry, I didn't see you there. Sorry.
No, that's okay. No, I'm so excited that this was included as part of your information, because it is a very exciting opportunity, and we're really thrilled to see the excitement and the encouragement of the community coming to support this program. So we are in the middle of the review and approval process right now. I'll actually be sending out a notification in a moment, a little bit later after this call, to just let the applicants know that there's been just a slight delay in the notification process. We expect letters of notification to be going out at the beginning of March, but this will the membership committee has a hand in this process and reviewing the letters of recommendation. And so they'll be, as we go through this inaugural year, be thinking about when exactly this will open again for this upcoming year. And so we'll, of course, keep the PCs informed of when the application becomes available. But there is information online, and I can drop the link into the chat just if anyone is interested in reviewing that, especially anyone that's new that is not necessarily familiar with this program. I'd be happy to drop that link into the chat. It's online on our website for those that might be joining from YouTube or whatnot too. It's on our website, and there's all of this information on the qualifications, as well as information on the letters of recommendation and CVs and all the requirements. So yeah, and if any of you have questions, please don't hesitate to reach out to me too. I'm happy to answer any questions as well.
Thank you so much, Nikki. Yes, I really feel passionately about this. I can see a few faces already on the screen who I'm thinking, I'm really hoping that they're considering this, because there's some exceptionally worthwhile candidates in the pathology community, I think, who should seriously think about doing this. So I think that is the end of all of the housekeeping. So unless there's anything anyone else wants to mention before we go on to a very highly anticipated presentation.
Can I just, I won't take any time from
no,
Bobby, but
yeah, go ahead, Anya.
just quickly, I'm part of the College of American Pathologists autopsy committee, and we are thinking about putting together not guidelines, but just kind of an exemplary what people should do when they encounter an autopsy of a patient who underwent lung or heart transplant. Not as extensive as the guidelines, what we do right now, but just some guidance for autopsy pathologists who are usually not trained in pulmonary or heart. So would the pathology community interested in just reviewing what we put together and maybe put some input together? Could I send it around once we have it? And would it be okay if people comment on it and see what we think? Or is there another approach we should take?
I was going to say, from our personal point of view, we're actually going through this because autopsies in this country have dropped dramatically in number, and accreditation within the Royal College of Pathologists has the registrars don't have to do autopsies as part of their training. So it's becoming more and more in the forensic field. So we just last year stopped doing autopsies in our hospital. So we did all of our heart transplant, lung transplant patients in-house, and the rest went outside. So we've just stopped doing it, and we're in the process of trying to link up with the forensic unit, and we are actually trying to put together a manual for them as to what to do with the transplant patients, and then hopefully they'll send the slides back to us for a second opinion. So we would be greatly appreciative if you come up with the guidelines, because that would help us, because as you know, it's very different how we approach the autopsies for the transplants compared to the general. So from my personal point of view, we would be grateful if something like that, a document like that, was put together. I'll open the floor if anybody else has any.
Hey, Anya, so is this project already almost done and you just want us like kind of like comment and review, or this is the project just going to
Hasn't
start?
started yet. Was just an idea. We are
Okay.
really in the beginning. But we
Okay.
wanted to reach out to ISHLT because, there are only 2 or 3 people who are experienced with transplant on that committee, so it would be really nice if that would be kind of a collaboration.
I'm not in that CAP specific committee, but more than happy to, we can, discuss more. Like my number as the autopsy director is numbered, only 3 more months, but I would love to help in any way, especially we recently just reviewed all the transplant we did here at WashU for both heart and lung autopsy with our 30 years of experience. So I would love to, have this discussion with you, maybe in other meetings or,
Good.
I think
I'm
that's a
glad to hear
really good
that. Yeah.
idea.
May I
Thank you.
just add that it would be lovely if you just put it in, even in the American Society, that you may put in a recommendation that the slides should be reviewed by the pathologists, because I had this issue in Berlin. We were performing around 100 autopsies per year for transplants and for MCS patients. But once they went to forensics, even though they had no formal training, they were really happy to report on the pathology findings, which then went to the jurisdiction and resulted in a verdict. And afterwards, they had to go back to us if, it's a long story, but it would be lovely at least, if none of the European colleagues participate, to put a sentence in the guidelines that at least the histopathological section should be reviewed by a properly trained cardiothoracic pathologist with expertise in heart and or lung transplantation, because that would help a lot in arguing with the legislation, in particular in Europe, where a lot of the, nowadays it's being completely separated, pathology and forensic medicine. Previously, they shared some common education, as you know, but nowadays you don't have any influence, you don't know your colleagues, and you just get to contact them via the court. And this is extremely disturbing and difficult, even if you have to reassess the cases within your own hospital. So that would be lovely if you can take it into account, and I'm happy to provide any kind of insight if you like it. Thank you.
Very good. Thanks, everyone.
I don't know if this is the time to provide the feedback. I think she's just asking if she could send the paper around and then we can review it and provide feedback offline. But I don't think we should be spending much more time talking about this. Thank you.
Yep.
Can I add? Anyway, some of this information, I think, will be part of the guideline of native and explant lungs or heart, because a retransplantation, for example, the native lung and the retransplant lungs and the retransplant heart will be evaluated following the specific guidelines. So some of this information, I think, will be already part of the guideline we are writing, no?
Yeah.
Yeah. It's true.
Yeah.
And I think there's some information in the chat too, Anya, from Annalisa and Greg. So, but thank you for that excellent point. And we will move on just in the interest of time. And I don't know, Bobby, if you want to share your screen, but I'm just going to, most of us on the call know, Bobby, his reputation and his excellence in work, but just for those who may not, I'm going to give you just a quick introduction. So he's a pathologist at Brigham and Women's Hospital, an associate professor of pathology at Harvard Medical School, and faculty in the Harvard MIT Division of Health Sciences and Technology. He received his Bachelor of Science degree in both biomedical engineering and chemical engineering from Northwestern University, a PhD in medical engineering and medical physics from MIT, focused on medical devices, and an MD from Harvard Medical School. After medical school, he received his residency training in anatomical pathology at BWH, with further fellowship training in cardiovascular, pulmonary, and autopsy pathology, and he spent a year as a medical device pathology fellow under Dr. Frederick Schoen. He has authored approximately 200 original publications in the areas of cardiovascular, pulmonary, pathology, biomaterials, and medical device pathology, and he's co-authored approximately 25 book chapters and reviews on cardiovascular and pulmonary pathology and cardiovascular medical devices. He directs the autopsy and cardiovascular surgical pathologies at BWH and also has clinical responsibilities on pulmonary surgical pathology. And he's an attending pathologist at Children's Hospital Boston, primarily serving in the cardiac registry, and he is the director of the first-year HST pathology course at HMS, as well as teaching in many other preclinical medical courses and engineering and business courses at MIT. So he's very qualified to give this talk, and we're very grateful for his time and generosity in presenting this. Thank you.
Well, thank you for that very kind introduction, and thanks for the invitation. And I will be mindful of time. So as I'm an engineer by training, it's great to see many of you who I haven't seen in a while. I was more involved in ISHLT pre-COVID, and I'm looking forward to re-engaging now. So I'll see you all up in Toronto. So I thought, as I was putting this together, was interested in talking about a lot of different things. I kind of narrowed the focus really to VADs and really to contemporary VADs, and kind of what some of the things that we see both kind of in at autopsy and in explanted devices, kind of going along with Anya said, kind of what to look for when you get one of these, and hopefully this will be some review and some other kind of insights maybe that I can share. So we'll go over just a brief introduction on VADs. We'll talk about, for the current generation of VAD that I think most of us see, the HeartMate 3, some issues related to the inflow cannula, the outflow graft, tell you a little bit about what we do at Autopsy to interrogate these devices, and how that can help with kind of cause and sometimes even manner of death. And then there's a curiosity in the inflow cannula and these HeartMate 3 devices, and just kind of what that is. And then happy to take any questions. So this is kind of a diagram of left ventricular assist devices through the years. I am old, and so I've kind of seen all of these go through their history, the HeartMate 1, the XVE, the HeartMate 2, the HeartWare device. None of these three are implanted anymore, and really what we see mostly, at least in the US, is the HeartMate 3. They all have slightly different pathologies because they're different types of devices, and as the devices have gone through, we've kind of seen different things. So in the HeartMate 1, we would see they had an inflow and outflow valve that were bioprosthetic. We often would see tears within these valves. That's how they would fail. This mechanical pumping chamber, there's a lot of metal on metal, so you get wear debris, so it would wear out in a similar way that your car engine wears out. It's a big pump. It's a huge device, and so sometimes it would erode into other tissues and organs in the abdomen. This device actually eroded through the stomach, and so the green you see there's actually bile from the stomach around the pump. And then there was some thrombus in these devices, but patients only had to be on aspirin for anticoagulation with these devices. The HeartMate 2, which is a axial flow, continuous flow device, had its own challenges. Patients had to be more immunosuppressed. There was an increase in thrombosis in the device, particularly at the inflow bearing. So right there, which would be right here in the schematic, there was an increase of thrombus formation that could cause the pump to fail and also lead to embolic disease. Because of the need for more anticoagulation than just aspirin, there were kind of clotting and bleeding as the two sides of the same coin. Could have central nervous system hemorrhages elsewhere in the body. Part of that was the anticoagulation, and part of that was the continuous flow device giving an acquired von Willebrand factor deficiency that led the platelet part of the coagulation cascade to be not as robust. The HeartWare devices had a peculiar design configuration where the inflow cannula was partially centered, partially smooth, and that left a gap right here that looks really small, but to platelets is really a big gap. And so we would consistently see thrombus that was forming at that centered, smooth interface, and led to thrombosis and a lot of thromboembolic complications. The thought was this third generation device would be better than the second generation HeartMate 2. That did not turn out to be the case when it came to thromboembolic complications. And so that brings us to the current generation, the kind of the HeartMate 3 device that has it's a third generation centrifugal flow type device, slightly different configurations, but just kind of show you some of the things that we've we've seen in some considerations when we look at these devices. So here's the kind of schematic of the heart that people generally should recognize. The body of the pump here. There's a bend relief that was put in soon after it came on the market. There's an outflow graft housing. This area here, the Dacron graft inside of it sits right underneath the sternum. So this here is meant to protect the graft so it doesn't get squished by the sternum and compress. And then, of course, there's the drive line that gets tunneled in the subcutaneous tissue. When we look at the kind of the inflow cannula, these devices, as patients have them for longer, the device can actually change its orientation relative to the heart. These chest X-rays, the technique is pretty similar. They're angled about the same way, but over the course of about a year and a half, the orientation of the device has changed based on the not so much the position of the patient, but as the patient might have gained or lost weight, and as the heart reversed remodeled after the VAD cannula, or after the VAD has been in. So where the cannula went might not exactly be where it ended up. This is just a kind of a 4-chamber view with the heart filleted open, right ventricle, left ventricle, interventricular septum. There's the inflow cannula, well positioned, kind of sitting right beautifully in the middle of the chamber. It's a little inflow pannus there. And that's kind of what you'd want to see, the cannula completely free. We've seen many cases, and one of the things to look at is where the inflow cannula ends up, either at autopsy or at time of transplantation. Here, there's a cannula that actually eroded through the interventricular septum and led to an acquired ventricular septal defect. So blood from the right ventricle was coming over to the left side and getting entrained into the pump. This is a heart-wear device that over time, you can see the inflow cannula has kind of migrated into the wall of the left ventricle, very thick wall, very small cavity. And so this can lead to inflow issues, restriction of flow into the pump because of obstruction by cardiac structures. This was the old-timey Thoratec PVAD cannula that sat in the left ventricle. This one here kind of happened to trap one of the chordae of the mitral valve as it went through. So thinking about where the inflow cannula is and evaluating that is important, especially when the inflow cannula pushes up against or gets very close to the wall of one of the left ventricle or the interventricular septum. Often that's a nidus for thrombus formation, as we see here at the tip of the inflow cannula of a heart-wear device. Just a brief scientific diversion. So this is work from Karen May Newman, who's a engineer at San Diego State University, who's done a lot of modeling and experimental work on thinking about the cannula and the cannula position within the left ventricle. You can do both computational fluid dynamics and also actually experimental systems. This is done with beads that you can track their progress through the cardiac cycle. And there's 2 different cannula designs here. This is what we're familiar with the cannula sticking into the ventricle a certain amount. And this would be more if the cannula had a position more like a floor drain, or like the drain of your shower, where it doesn't stand up into the ventricle. And so you can see how the flow profile might change around in inflow cannula depending on how far it's embedded into the left ventricle. The takeaway from this is, as you have the inflow cannula either at the surface, this kind of tipless design, or more embedded into the ventricle like ours, you do get different profiles, and you get different flow profiles at different points in the cardiac cycle. These are all maps of velocity of blood, where white is really, really fast and blue is really, really slow. So you can see at various points in time, you do have areas in the heart where there can be really slow flow and stagnant flow. And I'll draw your attention down to this bottom panel where you have a relatively, still a good flow rate, but with embedded into the ventricle. You can see right at the kind of the base of the cannula, most of the flow is going in through the top here, but in this area that I would consider to be the gutter, if you will, below the tip of the cannula, you have very slow flow, and that doesn't get washed particularly well. And this was one of the factors likely leading to the thrombus formation around the cannulas of the heart-wear device, in addition to that little rim that's there. So thinking about the inflow cannula is important in evaluating these devices where it is, there's thrombus around it. The outflow graft is also interesting, especially in that area that's protected under the sternum. So when we look at the outflow graft housing, you have the inner dacron graft where the blood flow is going through, and that dacron graft is actually permeable. So you can have leakage of plasma proteins and fluid through there. This bend relief has a Teflon sheet that's impermeable. And so material can get trapped and does get trapped between the dacron graft and this outflow graft housing. And that can lead to obstruction of flow in the outflow of the pump. So these are cross sections through that outflow graft. Here's the inner dacron graft here. There's the outer Teflon impermeable housing. And then there's the blue here is the plastic ring, that's the rigid ring. You can see there's material kind of built up here that's narrowing the lumen of the outflow graft. And that can be seen by imaging in some cases. But this can become really severe and give rise to quite a lot of outflow graft obstruction and lead to kind of failure of the device for the patient. Some are more, some are less. When we look histologically, this is a section of that inner dacron graft, the outer Teflon material, and the stuff in here is just proteinaceous material. It's not super exciting to look at. It's just kind of protein. There might be some dead cells and cholesterol debris, but that's really all it is just kind of this proteinaceous leaking material. And it's one of the design, if you will, features slash, you can think of something to be improved upon with further design. Just a couple cases of kind of thinking about these in the autopsy setting. I'll just give two quick cases where looking at not just the pump, but kind of getting information back from the manufacturer from the controller about what the pump was doing and feeling over time. So this first case is someone with heart failure with an ICD had a HeartMate 2 device in for about 2 days, for 2 years, excuse me. He was at home alone all day, and when his wife got home from work, found him down with the bad equipment nearby as if he was making a controller change to change the battery out or change the controller out. The wife connected the driveline to a second controller, which worked, which restored the pump function, but the patient didn't regain consciousness. Patient went to we notified the ME, they declined the case, and we did the autopsy and didn't really find any other anatomic cause of death. But when we looked at at the devices, at the log, essentially, the log files of what the VAD was going through, he had been disconnecting and reconnecting himself over the course of the day, and finally completely disconnected the pump at 1542. And then again, the log file picks back up at 1814 when the wife came home and reconnected the pump. And then they terminally disconnected the pump about an hour later, and the patient died. The controllers and all the batteries were fully functional. So the pump seemed to be working, was just disconnected. And then we looked at the ICD, and we noticed that there was an episode of VFib arrest that happened about a half an hour after this last disconnect. And the ICD appropriately gave some shocks, but weren't able to kind of get a perfusing rhythm back. So this was a case clearly where the individual had disconnected and reconnected the pump, and for some reason didn't reconnect himself after this period of time, and the cardiac issues then happened later. So we know the pump had an issue first, and then the heart failed and went into VFib at that point. The second case, not a dissimilar story, had an ICD put in and had a HeartMate 3 put in. He lived up in Maine. He had been apparently doing fine, lived by himself. And then the neighbors one day had heard his VAD alarm going off, found him deceased at home, and came to us for an autopsy. This was his case. He had the HeartMate 3, big heart, had cardiomegaly, had ischemic heart disease. Ventricles in the atria were dilated. There was, kind of apropos of what we discussed before, the LVAD inflow cannula had been angled into the ventricle, so there was some obstruction of flow. There was some thrombus within the pump and the inflow cannula there. And here, when we interrogated the device, it turned out that around 2:30 in the morning, there was VF and a therapy was delivered, and then another episode of VF with therapy delivered ineffectually. And then, 7 minutes later, the LVAD controller started to have low flow, and the flow eventually went to zero throughout the course of the morning. So this was a case where the patient had a primary cardiac event with the VAD in, was getting shocked appropriately, and then after that, when the heart stopped, the LVAD started to fail because now the right ventricle is no longer pumping, and the pump can't suck blood from the right side to the left side efficiently, and the VAD ended up failing. And when we did the autopsy, we found a standard issue myocardial infarction. So there was a acute plaque rupture and thrombosis in the coronary arteries. This was the etiology of the VF arrest, and then the VAD failed later. So we were able to kind of, in both of these cases, piece together the chronology of what happened, and in some cases why, through the autopsy and then interrogating the VADs. So I would encourage people, if they haven't been thinking about this, or just to say that there can be cases where this can be very helpful in sorting out what happened around the time of death. Then finally, what's that stuff in the inflow cannula? We occasionally see this phenomenon in the HeartMate 3 inflow cannula. When we look kind of down in there, this case also has some pannus at the inflow edge, but there's some material in the lumen of the device. In this particular one, the resident called me in and said, "I think there's fungus in the inflow cannula," because they look like little kind of little bumps. And the surgeon, who was made fun of by his colleagues because he looked down in here and said, "It looks like there's little mushroom caps growing in my inflow cannula." And they're really soft and friable. You can see there's a little path here. I scraped a spatula over the top of it. They came off very easily. When we look at them under the microscope, it's just thrombi, it's just bland, platelet-rich thrombi, no infection. They're very, very soft and friable. They probably break off, they get sheared up in the pump, and nothing ends up happening. This is a immunohistochemistry for CD61, just showing that this is basically just a big mass of platelets that's there. So anyway, so I wanted to kind of, I guess, thank you for the invitation. I've gone a couple minutes over, but just wanted to share maybe some insights and some things to think about when you're looking at these devices. This is actually a case, I don't know, Greg, if you saw this case, if you remember this case, but one of our clever surgeons used a heartware device as both a left ventricular assist device, and they also used one as a right ventricular assist device. So they implanted this pump into the right atrium and then had the outflow go into the pulmonary artery. So it was using it as a right ventricular assist device as well. This was from 2016. This patient is actually still with us, got transplanted, and is doing well still. So anyway, happy to stop and entertain any questions, hopefully in some discussion.
Thank you so much. That was a fabulous talk. I think Greg is actually just left, but just before your statement, because he has another meeting to go to. I'll open the floor up. If anyone else has any questions, we might just take one or two because we're sort of running close. If anyone has, I have one quick question because I know, like in Australia, the LVADs go in and it's usually a bridge to transplantation. They don't, we don't have them for more than, say, 2 to 3 years maximum. But I don't think that's a scenario in the Northern Hemisphere. You do have the LVADs for much longer periods of time. So I'm assuming that the pathology that you would see is much greater. What sort of is the maximum time frame that you've had patients with LVADs?
So especially with the new generation, with the kind of the HeartMate 3 type devices, which have been out for probably 10, 11 years now. We have patients who are 7, 8 years out as destination therapy, what's termed destination therapy. So they're not transplant candidates for whatever reason, but they're still, suffering from and likely to die of their heart failure. So they get the VADs put in. And really the things that we see kind of at either at autopsy or if they need another intervention, with the HeartMate 3s are that outflow graft issue where you can get obstruction of the outflow graft by the proteinaceous material, change in position of the pump from the again, didn't talk about it, but the HeartMate 3, that rotor is magnetically levitated in the chamber, so there's no metal on metal. That the pump, from the pumping standpoint, is essentially going to last forever. So it would have to do with things related to clotting and bleeding, those issues, some issues with the driveline infections, and then are kind of the main issues. But I think there will, and again, the cardiology and MCS people probably have a better opinion on this, but there may come a day, and that day may be coming sooner rather than later, when there will be a real question of whether a patient wants a destination VAD versus a transplant, depending on what their underlying pathophysiology is, how aggressively immunologically active they are versus not. Because the survival curves, I predict, are going to start to come very close to each other, if not cross at some point hopefully in my career.
I can see a couple of hands up. My apologies, Annalisa, and then go ahead, Annalisa.
Yeah. How often do you experience infection? Because you mentioned that there was no infection in the inflow cannula, but how often do you have infection in your experience with this device?
So at our place, I think it's relatively rare. We see it. I can't remember the last time we've seen infection at autopsy in one of the VAD devices. That's not to say, though, that you don't have localized infections around the driveline at the skin insertion site, but those can be managed largely medically. I don't think I've seen a device replacement for infection in years. So I think it depends on the center too, the experience of the center. We've been doing this a long time. Our surgeons and nurses and cardiologists are amazing at keeping patients out of trouble when it comes to infection, or at least keeping the infections as a chronic condition that don't end up becoming systemic and causing greater problems, especially if they're in the kind of bridge to transplant group. And the drive lines now being kind of smaller and thinner, there's less material. So I think the design has also helped with reducing the rate of infection.
Thank you.
Okay, Carmela, I can see you've got your hand up, and then Katerina, I think so, the last two.
Hi, Bobby. Thank you for the presentation. How often do you see, or what is the significance of seeing this platelet thrombi? Because we also see them, and I don't know if they're just kind of incidental, or is it really clinically important?
Yeah, I think what I showed, if I kind of flip back, this stuff that's in the inflow cannula is completely incidental and benign. This is so, like, when you again kind of scrape it, it's so soft. Those things break apart when they go into the pump and are subjected to more shear, and they don't lodge and embolize in any places to cause disease. So it probably has to, well, a hypothesis would be that it probably has to do with certain individuals' response to aspirin or some of the antiplatelet drugs, that they may do this sort of aggregation within the pump, or a sensitivity to some of the medications. It's all conjecture and hand waving, but they don't seem to cause any problems downstream of them. I think it's because they're so soft and so friable, and the shear within the pump kind of makes them into much smaller particles that essentially end up dissolving over time. It's like a lot, as I would tell my residents, it's like so much of pathology is just recognizing something for what it is and not calling it something different, or not attaching more of a significance to it than it should have. And I think this is one of those cases where you can see it and talk about it, but it's not going to do anyone any harm. It hasn't done anyone any harm.
Yep, and final question from Katerina.
Oh, thank you very much. It's just more like a comment. So basically, I agree that it's most of the infections depend on the country and on the program. For instance, I think it's South Korea, they have an infection rate of nearly 0. But when we performed the autopsies, which were quite a lot, I think about 70 per year, I did a microbiological examination on the entry point of the cannula, and where there's the transition to the skin as well as from the heart. And basically, even though there were no signs of infection, almost 100% of the patients showed a colonization of the cannula, which is connected to the battery. And in cases, there were severe cases basically which were biofilm producing, which afterwards led to a replacement of the entire LVAD. So it really depends on the circumstances, and also I wouldn't expect it, but also if you have pets at home, in some instances this appears to have an impact on the colonization, even though not on the infection, obviously, but almost in all cases of the autopsies we have performed, there was a colonization. So you can't really help and let's say save yourself from or prevent from supercolonization of your variables. Just as a comment.
Yeah, thank you. And I totally agree. And from the engineering standpoint, design standpoint, one of the potentially maybe holy grails is to try to have a completely implantable pump where there's no drive line, and you can charge a battery through the skin, just like you charge your phone on a charger. Transcutaneous energy transfer and not having to have a physical connection between the inside and the outside world would prevent a lot of those. What brings other issues and other complications, but that going through the skin and the issue of colonization and going up the drive line, if it stays just on the skin surface, you're okay. But if it goes up, as you say, then it can be a real problem.
Thank you so much, everyone, particularly thank you, Bobby, for exceptional talk. I'm going to actually make sure that my registrars have a look at because they're the ones that are cutting up the explants. Thank you so much for all the community members for joining, and also for your input. I think we are running out of time at the moment, so I will say goodbye to everyone, and I look forward to seeing everybody in Toronto, and hopefully we'll have a bigger turnout than last year, which will hopefully be good. Is there anything else anyone wants to say before we finish? Otherwise, I will close the meeting. No? Okay.
Thank you very much.
Thank
have
you
a great
all.
have a great night, have a great day, and thank you, everybody.